On behalf of Indian Rheumatology Association, I welcome you all to our web meeting, which is an innovation in reference to the challenge of coronavirus. And as you all appreciate, we have started feeling and started appreciating that we are living with this coronavirus. We have to live with this coronavirus. The things should move. And we have planned from IRA Forum a mixed bag of national and international luminaries on rheumatology. And the first segment is rheumatoid arthritis. We had yesterday a very exciting program. And today we are having the second part of it. So I can assure you that you would enjoy the whole sessions with all the contributions from the faculties, and you would get enough of time for interaction. And through this interaction, we can enrich our wisdom and so that we can translate the concept from bedside to bedside in clinical practice. Thank you very much. Let's enjoy. And now to moderator Dr. Rath and Dr. Chandrasekhar to initiate the program. Thank you.
Thank you, sir. Thank you so much. So all of you, welcome to this webinar. And we have a very interesting session lined up, some very fantastic speakers and some very good topics. Going ahead with our first session and our first speaker and our first topic. Now, all of you know that disease, the rheumatoid arthritis, today we need to control the disease very tightly. And to control the disease tightly, we need to first assess the disease. So on one hand, we have all these various outcome measures with us. But on the other hand, in our country, there are people who are looking at 80 to 100 patients a day. So how practical is it? Is it really practical in our setup to do this? And for that, we have a very eminent speaker, and it's not only my privilege, but my honor to introduce Professor Rohini Handa, former professor at the All India Institute of Medical Sciences, currently senior consultant rheumatologist at the Apollo Hospital, Indraprastha, Delhi. Professor Handa, as all of you know, I don't need to introduce him to you. He's been the past president of the Delhi Rheumatology Association, the past president of the Indian Rheumatology Association, and the past president of the Asia Pacific League Against Rheumatism. More than 350 publications to his credit, and many awards. To name a few, I would say P.N. Berry Award, the IRA Oration, the Shakuntala Meechand ICMR prizes, and the list goes endless. But I think one of the best and the finest orators that we've had and we will ever have in this country, I would like to hand over to Professor Rohini Handa. Sir, please.
Thank you very much for the rather generous introduction, PD. Friends and colleagues, ladies and gentlemen, Mr. President, it's my privilege to start the proceedings today. And I've been assigned the task of speaking on disease assessment in rheumatoid arthritis. I have no disclosures pertaining to this presentation. Now, rheumatoid has the distinction of being the commonest inflammatory polyarthritis that we encounter in clinical practice. It is by no means the commonest joint disease that one comes across in the community. That distinction belongs to osteoarthritis. But in terms of inflammatory polyarthritis, it tops the list. Now, there have been three game-changing concepts in rheumatoid arthritis over the last few years. And I call them the T's of rheumatoid arthritis. Time to treat is the first concept. Rheumatoid is a time-critical illness. Time translates into cartilage, so you institute treatment early, and early treatment fetches you the best dividends. There is one caveat. In our country, patients will continue to present late, and it is never too late to treat rheumatoid arthritis, although earlier the better. The second game-changing concept has been the advent of targeted treatments, and it is these biologics and the JAK inhibitors now which have catapulted rheumatology to fame, to the center stage of all excitement in the biomedical world. And the last but not the least, the third game-changing concept has been treating to target, and this is what we are going to discuss today. Now, we have moved over from experience eminence, and eloquence to evidence. Rheumatoid arthritis is no exception. Subjective impressions about disease activity have made way for objective measurements, and this is called metrology. Metrology is so very different from meteorology, which is the science which deals with weather. What we are talking about today is metrology. Now, this slide has a listing of different days that are commemorated in the rheumatology community, so well familiar to all of us. We have the World Arthritis Day, we have the World Lupus Day. Not to be left behind, we have the Rheumatoid Arthritis Awareness Day, and so do we have the World Osteoporosis Day, and we have several others. But few of us talk about 20th of May. And the 20th of May is the day when the scientific community, cutting across disciplines, observes the World Metrology Day. And metrology is what we are going to discuss today. Metrology as applied to the discipline of rheumatology in the disease that is rheumatoid arthritis. And this is the logo of the Bureau of International Measures in Paris. This is the organization of metrology. And this is what we indeed need to popularize amongst the practicing clinicians. Rheumatoid arthritis is a multi-dimensional disease. We have different facets: disease activity, disease disability, structural damage, and at the center stage of which is the quality of life, and we have tools to measure these different domains. For the non-initiated, this is an analogy that I often like to give. For the non-rheumatologists in the audience, we talk about activity, disability, and damage in rheumatoid arthritis, and these are the validated tools to measure it: the time-honored DAS28, the health assessment questionnaire, and the presence or absence of erosions and joint space narrowing on plain radiographs. And if I extrapolate the concept to diabetes, this is what we as physicians have been doing all along. We have fasting and postprandial sugars, which give you a cross-sectional snapshot of glycemic control. The 3-month assessment, we have glycated hemoglobin, and we assess organ damage, the well-known neuropathy, nephropathy, and retinopathy by clinical assessment. Much in the same way, akin to diabetes, we have different facets of the disease in rheumatoid arthritis. And what I'm going to discuss today is mainly disease activity, but this is not to take away from the importance of the other domains of rheumatoid arthritis, which I have spelled here. And this is a slide which lists the different domains. You have different validated tools. Disease damage, you have radiographs, you have ultrasound, and you have MRs. Disability, mainly assessed based on questionnaires, and you have several of them. And you have those validated by the Center for Rheumatic Diseases in Pune and by Dr. Ashok Kumar at the All India Institute. So you do have the Indian versions of HAC also. And then you have, for quality of life, a variety of measures which are generic, disease specific. And it is not my brief to go into the details of all of these, and I shall confine myself to disease activity in rheumatoid arthritis. Now, there are several variables that are employed to assess disease activity. These could be simple joint counts. This could be the NSAID pill count. This could be the duration of morning stiffness, patient dissatisfaction, 50 feet walk time, grip strength. But what you need to, I think, emphasize is that we have individual measures on one hand and the pooled indices on the other hand. Single measures, individual measures are unable to capture all facets of the multidimensional disease. It is a statistical nightmare to get meaningful information, which is why we now have the application of composite scores, which allow for better consistency and application, increased statistical power, reduced sample size requirements. They do have a drawback that they cannot be broken down into individual components, but in modern day management, we talk about composite scores, and this is something which has evolved over a period of time. The second cardinal concept is status measures versus response measures. Now, rheumatoid is a disease in continuum. So what you have are snapshots, cross-sectional snapshots of the disease activity when the patient is sitting in front of you. That's called a status measure or a process measure, and this is more applicable to individuals than in the clinic. And examples are the DAS scores, the CDAI, the SDAI, and remission that Daniel Eletaha shall talk about later in the evening. In contradistinction, response measures or outcome measures assess the changes in disease activity over a period of time, and you have the well-known ACR 20, 50, and 70 criteria. Unfortunately, they assess improvement, they do not capture worsening, and they are applicable more to groups at the group level. In the clinic, at the bedside, you can't apply ACR 20 to the individual patient, and this fundamental distinction is important. So what you and I apply in everyday practice at the bedside are status measures or process measures, and I have listed some of them, and you can also apply these status measures to look at response, and I shall not dwell upon that because of lack of time. Now, this is a recent publication by the American College of Rheumatology, and this is a crowded slide, and this should not put you off. At the last count, a slew of measures to assess disease activity in rheumatoid arthritis, 47 when they counted it last, imaging measures, the health provider measures, laboratory measures, and we have the patient-related outcome measures. So you have a slew of measures, but if you look at practically applicable measures, they talk about 5, and this is what you and I do in everyday practice. Disease activity score, the CDAI, the SDAI, and we have rapid 3 and the patient activity scale 2. This is a recent publication that looks at the patient-related outcome measures, so very important in the modern day context when the patient and the healthcare provider are at an equal pedestal and have to have shared decision making. And this is an area of fertile research. This is the health measures, also known as the person-centered. Mind you, you don't call it patient-centered. Person-centered assessment resource from the NIH, in which you have the PROMISE tool, the neuro quality of life, and other measures, all of which put patient at the center stage, and these are patient-related outcome measures, and I shall dwell upon them a little while later. This is an example of rapid 3 applicable to patients with rheumatoid arthritis, propagated by Ted Pincus. You look at 3 questions, and these questions deal with physical function, pain, patient global assessment, scored 0 through 10, and this is the score you get, max of 30, higher scores indicate a poorer status, and this is routinely advocated and applied. And then we have the patient activity scale 2, and this is Fred Wolf who propagated these, and these 2 are rapidly employed. They are quick to administer while the patient is waiting. Unfortunately, in our country, where education at times is an impediment, these health assessment questionnaires and the patient-related outcome measures may have some problems. You do not have validated translations available. The lady will often look to her husband. She is afraid that she may score something wrong, but in the Western world, these are employed on a widespread basis, and they are as effective in measuring disease activity as the physician-derived outcome measures. A quick take on the joint counts. This is the mannequin showing the traditional ACR joint count, 68 tender joints, 66 swollen joints. The hips are excluded in the swelling, and these have made way for the simplified, abbreviated, truncated 28 joint count, just because it's in a busy OPD, too time consuming and cumbersome to count 66 joints. And this is the reason why you have a 28 joint count, but it doesn't take away from the clinical importance of the small joint of the feet. And this is the well-known formula that you and I have been applying, -28 score, and then you get the cutoffs, 2.6, 3.2, 5.1, and this requires a formula, and you have calculators that are widely available. And the subsequent editions of disease activity assessment have looked at simplified disease activity index, simple numerical summation of the joint counts, CRP, patient and physician global assessment, and CDAI, which is totally clinically orientated. And Professor Smolan's group, including Daniel Alitaha, have been at the forefront of research in this. And these are the cutoffs that are employed: cutoffs for remission, low disease activity, moderate disease activity, high disease activity. And you, as rheumatologists, we now know that we don't wait endlessly. We need to get the patient into remission. That's the target, failing which low disease activity, and 80% of that should come in about 3 months. So rheumatologists are physicians in a hurry. Now, there has been a trend to move away from DAS to CDAI and SDAI, and this has been driven by the fact that Professor Smolan and his group have been highlighting this fact. Tender joint has double the weight of swollen joint in DAS28, and people who are in DAS28 remission may have several swollen joints, and they have also emphasized the differential effect of therapies like IL-6 inhibitors on CRP, ESR. So if you look at trials with IL-6, what you have is a patient who's on DAS28 remission, yet the ACR70 response is lower. Now this is counterintuitive. How can a patient in remission still continue to have a ACR70 which is lower than remission? And this is to do with the fact that the IL-6 inhibitors lowers ESR and CRP, and the patients may still be left with swollen joints. And if you look at JAK inhibitors, they lower CRP more than they lower the ESR, and which is why you have this oddity happening with tocilizumab. And this is the reason why there has been a slow but subtle shift from DAS28 to the CDAI and SDAIs. Now, this is the last 5 minutes of my talk, and 2 quotations by Thomas More. One of the greatest problems of our time is that many are schooled, but few are educated. The second quotation is, nobody owns anything, but everyone is rich. For what greater wealth can be there than cheerfulness, peace of mind, and freedom from anxiety? And Sir Thomas More was the first person who coined the term utopia, Latin 1516, translated into English in 1551. And this is the task assigned to me. This photograph is not very flattering, looks like a prison mugshot. But if you look at what I was told to do, utopia versus real life. And this is what I intend to address in the next about 4 minutes. Now, when I looked at the topic, I thought they've spelled it wrongly. And when I dug deep in, what I found was utopia is an obsolete word. You have white, you have black, and then you have shades of gray. Utopia, dystopia, utopia. Utopia is a functional place, as I quoted Thomas More, a place where everybody is happy, no evil. Utopia is a good place, can happen, and dystopia is a bad place, and this is what I have paraphrased. Fictionalized idealism, which I would say Satyug. Utopia, pragmatic realism, which is Ramrajya, and then you have real life functioning anarchy, that is Kalyug for you. And let us look at this in the context of rheumatoid arthritis. What about disease assessment in real life? Three impediments come up. Clinical inertia. Many busy clinicians with workflow difficulties will just eyeball the patient and make a global assessment. Is the disease quiet? Is it active? And this eyeballing is very rampant no matter what we say, what we do. And then, of course, we have the patient preference. And this is the only trial that I'm going to present, traction trial. The acronym is almost a tongue twister. I won't go into the detail, but I draw your attention to what these investigators found out, that patient preference, and out of 90 patients, 1/3 of the patients had inhibitions in increasing their treatment in response to increased disease activity. And physicians on their part found that the disease activity measure was unrelated to rheumatoid arthritis. And this is what was elegantly put forward by Frederick Wolf, that RA patients may have a discordance between what they perceive as activity and the physician. And this is the bottleneck in real life. When you tell a patient that your disease is active, dawa padhani padegi, the patient says, doc, I'm doing fine. I think I can stay without increasing medication. And your disease activity measures also may reflect a discordance between your patient perception and what the measure shows. And that is why many people, these are the impediments to application in practice, and many experienced clinicians eyeball and treat. Ladies and gentlemen, we need to transition from utopia to utopia. Objective measurements are indeed superior to subjective impressions. They improve outcomes, no two words about that. We need to improve the uptake of this in routine clinical practice. The universal implementation is lacking for the reasons that I have outlined, and we need to work on all fronts. We need better measurement tools, and we need physician sensitization and patient education. The science of metrology has now transitioned from being a research instrument to an indispensable bedside tool. Look before you leap, measure before you treat in the disease that is rheumatoid arthritis. Thank you very much for your kind attention, and I'll be happy to take up questions.
Thank you, sir. That's wonderful, as always, very simplistic overview of such a difficult topic in our country. So I think what we have clearly understood is that the way to go ahead is to measure before you treat, as sir says. But what kind of measurement is very important, because it's very important that you use the same kind of measurement in your practice, and you can choose from a wide gamut of them. And as he has shown, there are pros and cons with each of them. And measurements again involve clinical assessments, radiological assessments, and so on and so forth. So, sir, we have people asking, so people are, as it is, very much moved by your talk, and we have questions. And let me start with the simplistic question by Dr. Arindam. He is asking from Hyderabad, sir, which is the one which you would use or you usually use in your practice? Which assessment do you use?
I use the clinical disease activity index, and I'm quite comfortable with DAS because you have calculators available, but I use CDAI, and also when I'm hard pressed for time, eyeballing. I would be less than truthful if I said that if I am racing against time, that I eyeball and look at a holistic thing. By and large, I try to look at the joint counts and use CDAI.
Right, sir, because Dr. Prashant is asking, because the DAS28, the problem with DAS28 is he says that, you know, the ankles and the lower limb gets ignored. what would you say about that? I mean,
No, they are also ignored in the CDAI and the SDAI because the joint counts don't change with the method. And I have told you that the influential group from Vienna has shifted the paradigm towards CDAI and SDAI. And this is because the trial data showed that when you were using IL-6 inhibitors, you get impressive -28 results, but less than impressive CDAIs and SDAIs. And I've showed you the results with JAK inhibitors, and that is why. The joint counts are no different. And I also notice a question on NSAIDs and can you use it as a disease activity assessment? Well, this NSAID pill count was the time-honored thing. It's no longer employed now because in a well-controlled patient, you seldom if ever use NSAIDs.
Absolutely agree. But I think the advantage of CDAI also is that, you know, it does away with the lab measurements like the ESR and CRP, which I think in our country is very dubious, you know, so many different labs, and every time the patient comes from a different lab, a different report, and sometimes it is an HSCRP, sometimes it is a CRP. So I think it really makes CDAI a very, very good assessment for our country. So Dr. Kunal has been asking a lot of questions. I must congratulate him since yesterday is very active. He's asking about whether there's a simplistic radiological score which we could use bedside for assessment.
I can't really say. There are several available, and the IRA has done a lot of workshops with Dr. Shankar, Dr. Vinod Ravindran, and outside of a research setting, what you look at is you look at joint space narrowing, you look at erosions, and you look at soft tissue swelling. And I have not done formal radiologic scoring in routine clinical practice ever. And with the current classification criteria for rheumatoid doing away with X-rays, in 1987, when the American College of Rheumatology criteria came up, erosions were a part of that. Every single person was subjected to hand X-rays, but now you see they have removed this because erosions come up late. I can't really give you the answer on the time taken to score, but we do have several methods, modifications available, and maybe people who have worked on it can give you a time taken to score. Do you count carpal crowding as erosion? Well, good question. Carpal crowding is more reflector of cartilage loss than anything. Ultrasound in assessing disease activity, yes, it's employed. I think PD is the person to answer this. I mean, he does ultrasound.
Yeah, I think ultrasound, again, as I think as has been shown, that most of the ultrasound studies have shown that if you do a clinical assessment, it's as good as doing a radiological assessment. It does. Radiological assessment has still now not proven in trials to be superior to clinical assessment. It's almost the same information, but yes, there are multiple Handa 12. So you can use anything. I use sonar group scoring. So it is important that you adapt a particular score. It doesn't matter which score, but as long as you're able to replicate that time and again, that is more important. Sir, we have another question about Rapids 3. How do you place it in your assessment?
I don't choose it because one, it is not translated into Hindi, and I find that the woman often looks at her husband, she is hesitant, and when you apply these questionnaires, whether it is quality of life, and we've applied sleep questionnaires, we've applied quality of life questionnaires, you need them to be translated, back translated, validated, and you just can't give a thing which is in English to a person to apply. So I actually don't use them, because what I find is that the people who come and meet us, the educational and the socio-economic background is very different. But having said that, we've tried it with sleep studies and we've tried it with quality of life questionnaires. There are some challenges, and I prefer to use CDAI.
Very true. I absolutely agree, because we did a study in Max with more than 200 patients with Rapids 3, and that was purely in English. We could not translate because there was no validated translation. And what we found is people overscore on Rapids 3 because of comorbidities like fibromyalgia and osteo. So that really doesn't give a good assessment of the right disease activity. Thank you, sir. So the next question, sir, is there any need to include hip joint and TMJ joint in assessment by Dr. Ashish Saha?
You see, the inclusion in a joint count does not take away from the clinical importance of that joint. Please remember one thing: if you have ankle arthritis, even if you don't score it in -28, it will impact the quality of life of the patient. and the ACR is very clear that, if you have a clinically involved joint, it must be recorded in the case notes. -28 is means to an end. The 28 joint count is means to an end, not an end in itself. So TM joint, if it is not scored, doesn't take away from the value of that.
I think a very interesting question being asked by Dr. Mahesh. He says, why is non-arthritic manifestations ignored in all the measures?
No, I think basically it's to do with the fact that you, in a multidimensional disease, you look at direct measures. You do not look at everything conceivable because it would become unwieldy and blunderbuss. The best is the enemy of good. So you try adopting the best and you will forsake the good. And this is what happens when you saw in the traction trial data. So if you try to include the impact of anemia, the impact of, as Professor Malviya yesterday talked about, the tip of iceberg, if you talk about coronary artery symptoms, if you talk about quality of life, if you talk about sleep, if you talk about sexual health, then you would require to sit one day with the patient, and the best is the enemy of the good. So let's settle for good and not aim for the best.
I think we just have enough time for the last one or two questions. Dr. Kriti Kishore is asking, in patients with clinical remission but serological activity, would you like to escalate therapy?
Absolutely not. This phenomena of clinico-serologic discordance and clinico-radiologic discordance in rheumatology has a straight answer. Don't chase the serology, don't chase the radiology, treat the patient. Watchful waiting is what you do, and you escalate only when the patient has things, and this happens all the while in conditions like vasculitides, conditions like lupus, where you have dsDNA levels which continue to be very high. In rheumatoid, because we don't order RF and ACPAs that very often, we may find that we don't really track them. But the dictum is simple. The rule of the thumb is treat the patient, don't chase the serology.
Thank you, sir. I'll just end with the final question. Very, very interesting from Dr. Ankur Dalal. In the present COVID scenario, how do we assess disease activity?
How do we assess the
disease activity in the present COVID scenario?
Oh, you ask the patient to then on a mannequin score the joints. Tell him that I am going to send you a mannequin by WhatsApp. आप उस पे निशान लगा दीजिए, and then whatever, that's what you try to do, and you say what is called the patient global assessment. रुपए में कितने पैसे तकलीफ है, and the youngsters don't get this रुपए में कितने पैसे और कितना आना. So you ask them that, what percentage, because I straddle two generations, so the youngsters don't understand this रुपए में कितने पैसे. They've never seen paisa. So you ask them the percentage and you get an answer. Even an illiterate person would be able to tell you that I'm 50% better, 70% better. So this is called eyeballing by the patient and eyeballing by the rheumatologist. Thank you very much.
Thank you so much, sir.
Dr. Rath, at the outset, I'd like to thank Pfizer for today's symposium. There were about 400 participants today, as against 500 yesterday. You would expect more on a Sunday, but maybe people are holidaying a little. So we expect that the topics and the speakers will be so good that we will have more next time. The speakers were very good this time, but we'll have to probably modify the talks a little so that there's more interaction as well. It was a lovely talk, very relevant to the Indian practice, because when you talk about not needing remission in every patient, even low disease activity, or not needing biologics and not needing those sophisticated biomarkers, it becomes very relevant for our country. So thank you very much. It was a wonderful talk. The other speakers as well, Dr. Handa, sir, Dr. Vinita, and Dr. Damodaran for an excellent overview. The moderators, Dr. Rath, Dr. Chandrasekhar for the questions, putting in the questions and ending it on time. Dr. Alkindu sir, Shenoy for all the work. And as I told you yesterday, we are maybe planning an Indo-UK sort of symposium in between, and also a fellows retreat, which we'll have monthly sessions for the fellows, and we'll be sending emails to you for all of that. And lastly, before we conclude and say that the next time we meet will be on 26th and 27th of September, which will be the Spondyloarthritis Symposium from the IRA. There is just this one request to all of you, and you can pass it on to your colleagues and also to the industry, that we try and avoid parallel symposia during the IRA webinar at least. We've been circulating for almost a month before. So if possible, try and avoid parallel, at least with this particular symposium. With that, I think I'll ask you all to stay safe. And if there are any suggestions, please email to me on the secretary email, which is there on the website. And please keep looking at the website for any updates. Thank you, all of you. Thank you again. Good night and stay safe. All of you. Thank you.